now that we're heading into afternoon. I'm looking to see if I don't think David or Tabitha is here yet. Let me see who just came in. I expect them just any moment. So I'm going to skip David's slides. And I still got some people coming in to the meeting. I hate for anybody to miss this part from Lisa. All right, let's go ahead and get started. Lisa Tenley, would you please talk to us about the logistics for the learning session?
Yeah, so the learning session is going to be on September 30th from 9 a.m. to 4:30 p.m. like we do online. And instead of having two different learning sessions, we're all going to have one together in person. Um, if you look at the invite, the calendar invite, the Outlook invite, you'll see the directions where you need to park in the Stonewall parking garage. And it also has a pathway you can walk from that parking garage to Nicholson. The actual learning session will be held in the Gandy Auditorium on the 5th floor of our building. Also, it'll be very important for you all to print the Dash Pass. And that's also in the calendar invite. It has a QR code you can scan to get into the garage. And you'll be parking on the top floor in the designated parking area. And that's also in the documents on the meeting invite. Let's see what else.
You can walk down from the top floor to is it the second floor that has the sky bridge?
Yeah.
So if it's raining or something, you won't have to walk outside in the rain. There's a sky bridge over the street that will take you directly into Nicholson, and you come in on the 4th floor, so then you can take the elevator up to the 5th floor. So you get to the end of the sky bridge and you keep going walking straight as far as you can go, and you'll see elevators on the right.
And if we need to, which I may just do anyways, I'll see if I can get permission to get some markers so that you can know where to go. It's not really hard at all. You just follow the sky bridge around to Nicholson. It's really intuitive. You'll see what to do.
Are we providing lunch?
No. Unfortunately, we can't, but we will have refreshments in the morning. I didn't know if Dr. Barr wanted to announce this part or not, because we're still hashing out those details, how everything's going to get paid for. But we're not allowed to buy lunch, unfortunately, but we will be able to do refreshments for the morning and the afternoon.
Now, Children's Hospital has a pretty good area where you can buy lunch. They have there's a small cafeteria where they have hot food, and lots of times when I'm on campus, that's where I'll go and have lunch, and I'll have whatever they have. And sometimes it'll be like a chicken pasta, other times it might be a beef and mashed potatoes and green beans. But then there's also Subway, and there's cold sandwiches, and there's a pizza bar. So you have options there, and we can direct you to you will have to go outside for that to go over to Children's Hospital, but it's just a couple of buildings down, and so that's a convenient place to get lunch. Then there's also, if you wanted to go down to the Student Union, that's another option that's down Stonewall Street. Lisa, is there anything you want to add about that?
No, not really. There's also a high TO in the Nicholson Tower. I think they just mostly have drinks and wrapped up lunches and stuff like that. Have you seen that, Lisa?
That HTO?
HTO, is that how
Yeah, like water,
HTO?
HTO.
Okay, I don't know. I'm thinking
But
high,
it's
like high.
HTEA, and so they have good iced tea.
Okay, all right. Yeah, I didn't know how to. I was like, what is this place? It's fairly new, and there's plenty of options. Maybe I'll get something typed up, but like Lisa said, it's just a short walk. You can Google the cafeteria even, and you'll get directions there. But there's a cafeteria, Chick-fil-A, and the student union lunch spot there.
And there's a decent barbecue place that's not too far if you wanted to leave campus.
Oh
It's
yeah,
just a few blocks away. George's.
Yeah, George's is pretty good.
Yeah.
Yeah, there's a lot of places around the campus and on the campus for sure.
So as you can see, I'm very motivated by food. So, all right. Does anybody have any questions for Lisa Tunley about the logistics for the learning session?
I also wanted to note that we have enough parking for 120 people. So if you can, I mean, I think that's more than enough, but if you can ride together, that would be optimal.
Okay, thank you.
I think
All
Angela
right.
had something in the chat.
Angela, did you have something in the chat, or was that just sent? That looks like that was just sent to you, Lisa.
Okay. All right.
Yeah.
I get it.
I have a brief interruption about something in the chat too.
Okay.
A request to allow Read AI meeting notes. It says it's coming from Michael, so I don't know if that's Michael Figgins, if he's on today. I don't have a problem with it, but if we approve it, I want to make sure everyone else is aware.
We get a notice. It comes up for us too.
Okay, and then is this the same AI note reader that Zoom uses, or a separate one?
I don't know. I'm not familiar with this one.
Yeah, I've never seen this. It seems like it's a different read.ai/pp.
Is anybody the owner of that?
I'm
Chat
trying to
request?
see who sent that. I don't know. Can't even grab their name. Huh. Maybe it's AI that's doing that. Wait.
I have a suggestion then. Why don't we, and I'll do it myself here. We'll stop that, but we can use the AI companion within Zoom, which we know is
Right.
HIPAA compliant, and then circulate those notes to the group after we vet them.
David, this is Susan. I've seen that in other meetings. If people can't attend, then they send their AI.
Sends them the notes afterwards.
Right, exactly.
Okay, David, do you want to go ahead and talk about the referrals, the big picture?
I do. I am going to stop this AI though, and then will you turn it on, Lisa, using the Zoom AI companion?
Lisa Tunley, please.
Yes.
It
Okay.
should be on now.
I don't mind, Lisa Deshay, but I'm seeing it in your notes view. If that's the way you want it.
No,
Not in your notes view. I'm sorry, you're in your non-presentation view.
okay. Well, okay. Is that better?
Yeah, that's much bigger. Thank you. All right. Well, we, in the spirit of being a learning collaborative here, we thought we would share some data back in the remaining times we get together as a group, including our monthly call. So you'll see a lot of data at the learning session next month. But here's a preview. And you've seen a lot of these categories before. So I'm happy to pause though and provide some additional explanation. I think we have Kayla on today too, who's an expert at what you're seeing in front of you. These are the generated summaries out of the Insight application that is part of our Unitas contract. So these are not the separate data sets that the evaluation team has been managing. You'll see report out on those. at next month's learning session. But for today, I have two of these to present. This one highlights the referrals that are managed and closed within 30 days. 30 days is sort of a benchmark that I think Unitas uses for a variety of their clients. And you can see that I think we're doing pretty well here. 74% of the time within a month, we have these referrals that are managed and closed. They also typically track the needs action status for us. I'm sorry, and they look at it a week at a time. So if a referral needs some new action 7 days after it was initiated, they want to throw up a flag. And you can see that that happens the majority of the time for us. So 80% of the time, there's still action that needs to be done a week after the referral is initiated. That may be par for the course and nothing we can do about that, but we thought we'd relay it back to the group so you're aware. Referrals pending consent. We know that this one's going to be tricky, and I'm actually surprised the percentage is as low as I see it here. Maybe I'm misinterpreting it, but how often are the referrals pending a consent 7 days after the referral is initiated? And it's saying 21%. That can't be right. But somebody correct me if they know the right answer there. All right, we'll get on top of that in our meeting with Kayla and make sure we have that explanation ready to go next month. You get a few more categories down below. You can see that to date, as part of the innovation project, we've had 216 referrals. It impacted 181 clients. Just under half of those have been accepted. About a quarter of those have been rejected. We do have some that are still in review, some that are recalled, a few that have been sent, and then some auto recalled and a forwarded. So I think the numbers to pay the most attention to there are the accepted and rejected, and bear in mind that some of these are new referrals. So we pulled this in real time. This was data I think pulled last Friday, and the new ones especially are likely to be in those categories you see at the bottom. Sending organizations, we've seen a little bit of shuffling here, but not much. Oklahoma City County, our C1 program, has about a quarter of the referrals to date. PCCT has just under that, and our Tulsa C1 program is right there, as is the LCDA. And then I don't know if you noticed, but 9 of your programs, and I think that accounts for everybody as part of the learning session, have submitted a referral through Unitas, so that's great. This was pulled a little bit before that. We're at 199 when this chart was extracted from the Insight app. And
well, there's a slight difference between how these two were pulled. This is set up to pull the referrals that were made to these 3 organizations, our 3 referral partners. The other one was pulled to look at referrals from all of our home visiting agencies. So the home visiting agencies could have sent referrals to partners outside of the innovation. This is limited to the organizations within the innovation, those referrals.
Okay, thanks for that clarification. I'm noticing that it impacts more clients somehow. Fewer referrals, but more clients, but just barely. So somewhat redundant information here. You can see when we crunch the numbers this way, we're just over half that have been accepted, still around a quarter of rejected. You can see your top 10 sending organizations are about the same, and say our receiving organizations, obviously the focus early on for most of you is either Sooner Start or Legal Aid, so they're quite a ways ahead of our PCAP program, but we're starting to see referrals come into PCAP. This is also meant to be a bit of a plug. So the Unitas licenses will continue after the grant ends at the end of next month. The evaluation data that we receive will not continue, so we won't have the more granular level data that we've reported back to you at the previous learning session and that you'll see at the end of next month. But you'll continue to have access to these Insight app reports, and we think it's a good idea to track that. I'm sure you would agree. I can't remember if every site gets access to this or not, but certainly your consultants and evaluation team at the health department will continue to maintain access to this type of reporting.
All right, thank you, David. So let's go over, I've talked about this a little bit in the rounding calls, but I just want to go over to what's expected for your presentation that you'll do in the learning session next month. So these are the parts of the presentation. You're going to have a part about your first PDSA, then you'll have a part about your second PDSA, and those may be about 5 minutes. Now, you can put these in any order you want. The third one, that's where we want you to take the creative approach, but some of you are putting all 3 of these in the creative approach, and that's fine with us too. And then there's the last bit that's sort of your evaluation, your assessment, your thoughts in general about the innovation project. So let's look at a little more detail on each of these parts. So the first 2 action phases, about 5 minutes each, you'll talk about your change idea. And you'll see, we've talked about this in some of the rounding calls. If you look at your PDSA, your title, and then there's a number for the change idea from the key drivers diagram. And everyone shows one of these 2 change ideas. So this is what was motivating the action phase. And so then briefly explain what you did and show results. You're going to want numbers and graphs from the retrospective dashboards that we have been sending to you. And most of those have a graph that shows a process, a disruptor, and an outcome variable in the same figure. Some, for a couple of programs, those are separate figures, and we had a specific reason for that. So then once you talk about what your results have been for these 2 action phases, not just during the action phase, but everything that's happened to date, and we will get you your last of these dashboards by September 26th. I think that's the date. It's the Thursday before the learning session. And so then finally, we want you to say, did you adopt it? Did you adapt it? Or did you abandon this change? Then for action phase 3, this is the creative presentation. And some folks are going creative for all 3 parts. And we need all those same things, but with your typical amount of details. So it's, instead of just being a big quick overview, you're going to go into a little more detail, telling the story like you've done through with these different themes the last couple of learning sessions. And we want to see your numbers and graphs again. And then the conclusion will be your opinion. And I distributed an email with 4 reflective questions and asked you to answer 2 of them. Or you can come up with your own question to answer. It could be that you'll meet with your team and certain things or themes or ideas will come out, and you'll say, well, this is a different question than any of Lisa's, so we're going to answer this one, and that's fine. We want to know your opinions, your observations, your conclusions. So questions about that? Okie doke. Thank you.
You mentioned
Now,
the
I wanted to mention one thing real quick. I have emailed you, I have emailed you a link to a REDCap survey. So this is for the home visitors. Please fill out that survey that I emailed you the link. Monica? Monica, did you have a question?
Did you say that you sent the questions that can you remind me what it was already sent last week, 2 weeks ago, or when?
I don't know. When I stop sharing my screen, this is taking over my monitor. I can resend those questions. That's a good idea.
Thank you.
Yep. All right, Tabitha. Do you want to share your screen?
Yes, please. All right, y'all. For the next little bit of time in our day together, I'm going to talk through, alongside Elizabeth Fankhauser, how disability status can be a social determinant of health. This was one of the requested topics in the survey we did back in June. We're so grateful for your input on what might be interesting or helpful to bring into these calls. Once we finish that, Kayla is going to present, and I'll explain that when it's time for her. And then last, we've got some folks from Sooner Success who will be talking about another requested topic. But starting off here, get it on my share screen. So we'll be talking about disability as a social determinant of health. And as we get started, I want to acknowledge and thank Dr. Laura Shamblin. She's one of our developmental and behavioral pediatricians here at the University of Oklahoma Health Sciences Center. She is also a faculty member of our LEND program, where they focus on curriculum to increase knowledge and advocacy for folks with developmental disabilities. And on the note that we're talking about disability, we think it's important for us to acknowledge our own statuses and how that might relate to our lens or worldview in discussing this topic. So first, I just want to acknowledge that I am a white cisgender neurotypical person. And while I work with children and families who are neurodiverse, especially families who have a child with autism and developmental delay, as well as families who have members who are deaf and hard of hearing, I am somebody who's privileged without a physical disability. I'm educated and I belong to several majority groups, such as being white.
And I wanted to say that first, I am a European American. I also have a bachelor's degree in psychology. I do identify as neurodiverse and have physical disabilities. And as same as Tabitha, I work and volunteer in communities that bring me in close contact with the people of myriad different disabilities. And I also wanted to recognize my privilege of education and not being visually disabled.
All right, so we're going to take some turns during our time this afternoon, but to start off with some key definitions. I know these are definitions that this audience is very familiar with, so I'll go through this relatively quickly, but want to acknowledge that we understand disability as any condition of the body or mind that makes it more difficult for the person with the condition to do certain activities and interact with the world around them. And then developmental disability is a group of conditions due to an impairment in physical, learning, language, or behavior areas of development that present during the developmental period and impact day-to-day functioning and usually last throughout a person's life. Intellectual disability is a diagnosis that involves an impact on general mental capacity as well as functioning and adaptive behaviors such as self-care and navigating the world independently. And then IDD is a common short term to reference folks who have intellectual and or developmental disabilities. And inspirational porn is the portrayal of people who have disabilities as being inspirational to non-disabled people on the basis of their life circumstances or accomplishments. And we included that because our hope is not to glorify folks with disabilities, but to really talk about their experiences and what language is accurate and respectful when talking about these populations. So how does this intersect with social determinants of health? It can in a number of ways. One is in their economic stability. So we know that folks who have disabilities are less likely to be employed. They're also 3 times as likely than those without a disability to live in households that are below the poverty level. They're more likely to rely on food stamps and rental assistance. They're more likely to be what's called food insecure, meaning not having confidence or surety that you will have enough to eat. And they're more likely to report high levels of financial worry. In the area of education, folks with disabilities are less likely to graduate high school or college, which can of course impact health, as we've discussed before. And in neighborhood and built environment, folks with disabilities are less likely to describe their neighborhoods as being cohesive or supportive. A couple of other spheres where we can think about disability and health is the social and community context. So people with disabilities are more likely to live alone. They're less likely to live with children, and they're less likely to be married or cohabitating, so not having that kind of social support network. For health and healthcare, people with disabilities are more likely to rely on public insurance programs such as Medicaid and Medicare, and they use significantly more health services, so higher rate of utilization, and they're more likely to report difficulties when they are trying to utilize healthcare. So it can be difficult to obtain and difficult to pay for. With regard to behavioral health care, I think it's important to note that people with disabilities are often excluded from research on clinical interventions. So they're not included as part of the sample to help us understand whether or not that intervention is a good fit for this population. And this unfortunately perpetuates the view that folks with disabilities cannot benefit from certain treatment approaches that we know to be best practice and is a myth, but we don't have the research to back it up. That's still building, and it limits our understanding of best practices for folks with disabilities. All right, we wanted to include some statements from folks with lived experience, since that's not a framework that I can bring to this conversation. So these are quotes from some qualitative research studies where folks with disabilities were commenting on their experiences in a couple of these spheres I talked about. So briefly, in the domain of healthcare, one individual said, the drug that helps me to process a certain medical process is drug name. And without that, I would be stuck in my chair for the rest of my life. And insurance has never wanted to pay for that, but they'll pay for pain meds. And drug name has gotten harder and harder to find. In terms of economic stability, another person said, when referring to their boss, and he said, if I had known that, i.e. that he had a disability, I would not have hired you, but you've done such good work. How in the world have you functioned? And then last, in community context, an individual shared, sometimes I have to cancel that appointment that I waited 6 to 8 weeks for at the last minute because of transportation issues. I can't ride the bus because it's too far to walk to the bus stop, and I really don't have a support system here. All right, and I'm going to pass it over to Eli in 1 second, but just very briefly, the medical model of disability understands it as a consequence of a health condition, disease, or caused by trauma that can disrupt the functioning of a person in a physiological or cognitive way. So the focus from a medical lens is on prevention, treatment, and curing the disabling condition. When you take it from a social model, this is a viewpoint that a person's activities are limited not by the impairment or the condition, but by the environment and barriers that are a consequence of a lack of social organization around supporting folks with disabilities. So this more so focuses on barriers facing people with disabilities, which again is a lens that fits well with our ideas of social determinants of health.
Next, we are going to be talking about accessibility, some of the issues that people have, and some of the things that are being done currently to help fix those. One of these examples is the Heads Up Act, which is an act which is currently in Congress. I believe it's in the House in a subcommittee currently, but it would be an act that would help designate people with IDD as a medically underserved population, which would affect a number of different things. It would increase access for individuals with IDD to more federal programs and agencies, would help with access to loan repayment and training programs for providers who work with individuals with IDD. It would help provide incentives for physicians to treat individuals with IDD by increasing reimbursement rates. It would authorize the Department of Health and Human Services to award grants to health centers to provide services for individuals with IDD. I know Tabitha mentioned before that a lot of research does not focus on disabled individuals, but this act would help potentially increase research due to preferences given to federal research studying medically underserved populations. Another act that is helping to make accessibility easier is the FAA Reauthorization Act. I can speak, which helps reduce the mishandling of wheelchairs. Airlines break 29 wheelchairs per day in the US, and that's only wheelchairs. That does not bring into account other mobility aids such as canes, crutches, and walkers. This act is a path towards allowing passengers to remain in their wheelchairs during their flight instead of the wheelchair being stowed underneath the plane, which is oftentimes what causes it to break, which is thousands of dollars to replace, and leaves the individual in a lurch of being able to transport themselves. And it is increased, and it would also increase and improve training for airline workers to interact with disabled passengers, which also causes many problems sometimes when people don't know what to say. Another act that is working with individuals is the Maxis Law, which would require all state-owned buildings to have universal changing tables, which can be helpful for a number of reasons.
One close to home. So to highlight something else close to home, I'm going to apologize on Eli's behalf for our timing. I don't think we have time to show the video. But this is a student who attended the University of Central Oklahoma. Eli, do you want to share some about this individual's lived experience?
Yeah, absolutely. They're an individual who she was paralyzed in a car crash and now uses a wheelchair. And she has run into many problems at UCO in order to move around successfully in her wheelchair with the condition of the parking lots, sidewalks, and also many times the accessibility button on the side of doors, the school would turn them off because too many people were leaving the door open and letting air out, but that caused her to not be able to get into class. And there's also a lack of elevators on campus as well. And so it's just thinking of how many things in the everyday life that a more able-bodied person would take for granted that affects a disabled person.
I encourage you to watch the video later. We're going to talk just briefly about a timeline of disability awareness and laws. We think it's important to know our history, but also recognize how recent this history is and the lasting impact it can have on modern day concerns for this population. And Eli, I might pass you the next one, but I'll do this first one. So in the late 1800s through the 1970s, here in the US, there was something colloquially known as ugly laws. And essentially this was where in some American cities, they had ordinances that prevented folks who would be classified as unsightly to be seen at all. So these laws deemed it illegal for any person for this exact wording, who is diseased, maimed, mutilated, or deformed in any way so as to be unsightly or disgusting object to expose himself to public view. So this was really difficult for folks with disabilities to navigate day-to-day life. Also in 1907, there was the eugenic sterilization law for people with disabilities. Indiana was the first state to enact such a law, which was in place for folks who they deemed as confirmed idiots, which was a term used in history to refer to intellectual disability, imbeciles and rapists in state institutions to be sterilized. And this law actually spread to 24 other states. And in 1927, there was an important case, Buck v. Bell, which was a decision of the United States Supreme Court, in which the court ruled that a state statute permitting compulsory sterilization of the unfit, including the intellectually disabled, for the protection and health of the state, and said that that did not violate the due process clause of the 14th Amendment.
Next, we're going to talk about the sort of civil rights movement era. First, in 1968, there was the Architectural Barriers Act of 1968, which required all buildings designed, constructed, or leased with federal funds to be made accessible. Moving forward, in 1970, we had the Urban Mass Transportation Act, which required all new American mass transit vehicles to be equipped with wheelchair lifts, even though the implementation of this was delayed for about 20 years and finally issued in 1990. There was the Rehabilitation Act of 1973, which finally became law, which was the first U.S. federal civil rights protection with people with disabilities, saying that no otherwise qualified handicapped individual in the United States should be solely by reason of his handicap be excluded from the participation in or be denied benefits or any subject of discrimination. Then we have supplemental security income, which is a U.S. government in 1974, which is a U.S. government program that provides a stipend to low-income people who are blind or otherwise disabled, or age 65 and older.
So just put into context how recent so many of these changes were, just to make the world more accessible. Eli, if you want to read through this one, then we'll transition.
Absolutely. In 1974, as Tabitha mentioned before, the last of the ugly laws were finally repealed in Chicago. In 1974, Virginia finally repealed their sterilization law, even though Buck v. Bell was still being used. In 1975, the Education for Handicapped Children Act, or IEPs, which I'm sure many of you are familiar with, was set into place. It was later reorganized as Individuals with Disabilities Education Act. But this act guarantees free, appropriate public education for all children with disabilities in least restrictive environment. And then in 1977, we had the 504 sit-in, which was a sit-in to help sign Section 504 of the Rehabilitation Act of 1973. It took place all over the U.S., starting in April 5th, 1977, and lasting until May 4th, with over 150 people refusing to leave their sit-ins. And the regulations were finally signed on April 28th, 1977.
And I apologize that we didn't have time to share the rest of our slides with you, but we have two other important topics to go over today. These slides will be shared with you at the end of our call. I want to just quickly highlight what else there is for you to take some time to review and reflect on. But we did cover how disability is a social determinant of health. But we had a little bit more in history and language because we think it's so important. So just a little bit more about what happened in the 80s and 90s with regard to laws that affect folks with disabilities. And then in this next section about how much language matters, Eli did a really thoughtful job putting together slides around person first and identity first language, what folks with lived experience say and what they prefer, if you're not familiar with that. And then ideas on what you can be doing as providers in the field when you think about language and folks with disabilities. So a little bit of idea about how to ask and words to say rather than not to say, and some ideas of some insults that can actually be very offensive, and thinking through why that would be important to remove from your everyday language. All right. Well, thank you for your time and attention. I hope you got to learn something, and this really did put into place and center why disability is a social determinant of health. Again, those slides will be shared with you at the end of the call. And if you have any questions on this topic, please feel free to direct them to Eli. And I'm going to pass it over to Kayla Woodbury, who's going to share with you all a little bit about this idea of what's an internal case versus a referral.
Thank you so much, Tabitha, and good afternoon, everyone. Looks like we're already in the afternoon. I just wanted to briefly clarify something with you all. As Dr. Bard mentioned, we're coming to the end of the project, and as we continue to move forward with Unite Us usage, we want to make sure that everyone clearly understands the difference between a referral and an internal case. And for the sake of time, I just want to clarify that an internal case is where you would put information, excuse me, that you do not want to have viewed by an outside organization. And I'll share my screen just to kind of walk you through what that process looks like. All right, so today in my demo environment, I'm logged in on this screen as a PCAP user. And as you can see, I am on Hanna-Barbera's client profile sheet, and I'm over on the Cases tab. So if I click on this open case, then I see that there is an open case for our demo emergency infant services partner. Now, as you can see down here, there is a document that is attached to this particular case. That means that if anyone who is working with this particular client, even if it's a sensitive service, even if it's physical or behavioral health, HIV or AIDS related, domestic or interpersonal violence related, legal related, if I added this to the case, and it was an external case, then that means someone from the outside organization could be able to view that information. So that would be what we consider a referral, which is the way that you all have traditionally been using Unite Us. Now watch what happens when I click over here. Same client, but now, as you can see under her open cases, there are 2 additional cases here. These are internal cases, meaning that the only individuals that would be able to view them are individuals that are associated with the PCAP organization. So as you can see, I could always upload documents here, and then the only individuals that would be able to access those documents that have been uploaded to the internal case would be users that are associated with PCAP. The process itself is really simple. When we go back to our cases tab, I would just create a new case here and put in some information about which program it was going to be assigned to, which user would be the primary worker, meaning which user would be adding the notes or any documentation that was needed. And then that would become an open case. And then just as with our previous cases, we would be able to close that out and still be able to track that information. But I just wanted to clarify for you all today that there is a distinct difference. And if your organization moving forward, if we're going to be collecting information that is sensitive in nature, particularly if you are an organization that falls under the 42 CFR Part 2 compliance standards, perhaps even FERPA and HIPAA, if there's information that you are uploading into Unite Us that does not need to be viewed by an external organization, then we need to be utilizing internal cases. Have no fear, because I know that was a really, really quick run through of that. And so I've created a how-to guide that takes you step by step. Those of you who remember at the very beginning of this project, we had a couple of how-to guides about creating referrals, and I've created another one specifically for internal cases that I will send over to Lisa Tunley to make sure that you all have access to as well. And then, of course, if you have any questions about creating an internal case and what that process looks like, then you can feel free to reach out to me. I'm happy to set up a meeting and go through some one-on-one training for you and or your organization. But I just wanted to share that with you all today. Are there any questions?
I have a question. So when you're within a client's profile, you can create a new case, and it's not a referral being sent anywhere. It's just documentation that you're keeping, like notes you're keeping for yourself.
Correct, yes.
Okay, thank you.
All right, thank you, Lisa. Anyone else? All right, well, thank you so much for giving me that time. Like I said, I'll connect with Lisa Tunley to make sure that she has a copy of the how-to guides. Don't be discouraged by the length. They're screenshots, so that's why it probably will appear a little lengthier. But again, if you have any questions, feel free to reach out and I'm happy to walk you through it.
So much, Kayla. We appreciate your time and your commitment to making resources so that we can keep this important information organized and accessible to us. So you'll have a great email after this call from Lisa, including the slides from today, the service disability as a social determinant of health slides, Kayla's tool, and last but not least, I'm excited to introduce Tiara Jackson, who is a member of our Sooner Success Program, who will also state who her co-presenter is. But they're here today to share with you a little bit about services or resources for families who have English as a second language. That was one of the requested topics for the social determinants of health. And they are experts at resources in Oklahoma. So Tiara and team, take it away.
Thank you, Tabitha. Hello, everyone. My name, as she said, is Tiara Jackson. I am the Family Partner Coordinator for both Sooner Success and the OU Child Study Center. I work on various projects, but my main role is to support families seen in our Jumpstart Clinic, as well as help families with TEFRA and coordinate their psychological evaluations for their children. For those who may not know, TEFRA is the Tax Equity and Fiscal Responsibility Act of 1982, which allows states to provide Medicaid, known as Sooner Care, to children with physical or mental disabilities who wouldn't typically qualify due to their parents' income. On a personal note, I am also a mama of a 4-year-old that is diagnosed with autism, developmental delays, chronic idiopathic constipation, and a really rare feeding disorder. As a caregiver, I truly appreciate all the hard work you guys do, and today's topics really touched home for me and were very meaningful. So again, thank you, Tabitha, for inviting me and my colleagues. I have Myra Rocha and Andy Cooper here today. And Myra, you can go ahead and introduce yourself.
Hello, everyone. My name is Mayra Rocha, and I am the Oklahoma County Coordinator for Sooner Success. I'm also bilingual. I am a parent to a 5-year-old who is living with autism, and I have another little girl who's 4. And so, yeah, today I just wanted to come on here and show you guys a little bit more of information about what Sooner Success is doing, and more information as well as what Sooner Success is. And again, how Sooner Success assists families in navigating a complex system. Families often need multiple services from multiple providers, are overwhelmed, and are frequently the only coordinator of the child's numerous services, have difficulty locating needed services in their community, must travel to several agencies while struggling with unreliable transportation, childcare, illness, and challenges. And I can guarantee that that's completely true because I myself have gone through it. Who we serve families with individuals birth to 59, developmental disabilities, chronic special health care needs, mental behavioral health care needs, abuse, neglect issues, medical diagnosis. There's no income guidelines, no qualifying criteria, and no application process. Where is Sooner Success located? In Oklahoma. We are a statewide program, and here's our statewide number. It's the 405-271-2710. Now, the direct referral to coordinator from family or service provider, there is an online, if you go to soonersuccess.com, or I think it's soonersuccess.org, you'll be able to hit on the right side of the screen. It says make a referral. That is the easiest way for a coordinator to go ahead and get that referral worked and get that family some help. Some resources and information. Here's just a little bit of examples. I'll read through some of them. Diagnosis is new. Terms can be confusing. Families need guidance through process. There's community programs. We can help navigate sooner care, eligibility, and benefits. Developmental disability services, childcare, respite, summer camps, transportation options, counseling, adult day programs, recreational opportunities, guardianship information, social security, so much more. Anything that the family ever has questions about, they can always contact a coordinator and we will for sure find that answer for them. Now, there is county coalitions. The county coalitions meet monthly, and we all have different types of people in our coalitions. There's always a family advocate. There are always people from education, physical health, community, emotional and mental health. Our goal is to identify and partner with services currently available, identify gaps in services, identify services currently unavailable, and explore new ways to bring additional services or increase quality of services in our community. Now, this is our coalition in Oklahoma County. It is called Supporting Minorities with Disabilities Coalition. And our goal is to raise awareness of all abilities and partner to strengthen coordination to improve services for families in the state of Oklahoma, with a special emphasis on the OKC metro area. Together, we will explore new ways to bring additional supports to the hands of underserved populations and increase the quality of resources available in our community. Now, through this coalition, we have done awesome events. Right here, you can see our Inclusive Black History Month. We had so many performers and they all were Black and they had a disability, and they got to incorporate that and also show us what great talent they have. We have an inclusive Hispanic heritage dance. Our first one was last year, and this year in September, we will have our second annual one. We have lunch and learns. Right here in the bottom, you can also see an ice cream social where you can see our community coming together. It's just honestly amazing. If you guys would like to be a part of it, please contact me or Tiara, and we can go ahead and help you out with that. Again, Sooner Success programs. There's on the road conferences, which is the on the roads are a little bit more of like what we do right now, but just in detail. Lifespan respite voucher, supplemental nutrition, healthcare transition, adaptive equipment and professional services, and sibling support. Right here, I want to tell you more about lifespan respite vouchers as to provide a much needed temporary break from caregiving. Give caregivers the ability to hire another person to temporarily care for their loved one. Care can be provided in the caregiver's home, someone else's home, a center-based program, or care center. Now, as a parent myself, I understand the high need of taking a break. And sometimes we just don't want to take a break, but honestly, guys, it's super important to have the caregivers take a break and use this respite for their mental health and also for the health of their child. Supplemental nutrition program. This is a program that, again, it's a supplemental to improve health, requests reviewed on a case-by-case basis. The program eligibility reviewed annually. The child must have a special, the child with special needs, birth through 17 years old. Documentation for oral use for a healthcare professional must include a diagnosis, date of birth, current weight, type of formula, quantity per day, months, or refills. Again, this is a supplemental, so it has to be a last case scenario. But again, I've seen a lot of cases that after 5 WIC stops, but if the child is still needing supplemental formula, they can contact us and we can coordinate that so that they could still receive supplemental formula. Adaptive equipment and professional services. Sooner Success, in partnership with Maternal and Child Health Services Title V, is excited to announce the role of the new Adaptive Equipment and Professional Service Program. Families who have children with special health care needs, birth through 17, who are not covered under Medicaid or another program are encouraged to apply. The benefits are $1,500 max per child for professional or adaptive equipment. This can include items such as any tool, device, machine that is used to help with any task associated with the daily living, as well as professional services such as recreational services, camps, and therapeutic and tutoring services. Applications are reviewed on a case-by-case basis. On this, I do want to touch note that the Wonderful Wagon are super popular, and a lot of our children with autism love my son loves the wagon, but that's also something that could be covered through here. Healthcare transitions. This is Ronelle Baker. She's the healthcare transition coordinator. Healthcare transitions is more of like telling families how to transition from pediatric to adult care services. SIP shops. SIP shops are recreational events designed for siblings ages 5 to 15 of children with disabilities or mental health concerns, aiming to provide peer support and education in a fun environment. They acknowledge the mixed experiences siblings may have, recognizing their significant role in supporting their brothers and sisters with special needs. These 3-hour events, typically held monthly during the school year, offer a blend of informational discussions, engaging activities, and game facilitated by trained volunteers. SIP Shops emphasizes the importance of siblings' natural support through their siblings' lives. The goals are to connect with others who understand their experiences, discuss both the positive aspects and challenges of being a sibling, share strategies for managing difficult or embarrassing situations, gain knowledge about their sibling disabilities, and learn how to advocate for their siblings. This is on the road conferences. We do offer on the road. There are one-day family perspective conference that assists families and caregivers who live in an individual with a disability and navigate a complex system. We have these, they're usually from 9 a.m. to 2 p.m. And we have different organizations like DHS, DDS, come and let parents or professionals know more about them and how they can get families involved.
I'm sorry, Myra, we're down to the last minute. So if you could just wind it up.
These are supports parents with disabilities, Lisa Simmons, and that's it. Thank you guys for nice meeting you all, and thanks for giving us this time to share.
Thank you. This was all really interesting. David, is there anything else you would like to say?
No, this is fantastic. Thank you, Sooner Success. Thank you, Tabitha, Elizabeth, for the presentation on disabilities. Great.
All right. Thanks a lot. I sure appreciate it, everybody. Y'all have a good day.
Thanks, everyone.